Welcome to this recorded presentation regarding Oregon's Crisis Care Guidance Draft. This is the same presentation that was provided during live public input sessions hosted by the Oregon Health Authority in August 2024. I want to acknowledge that we offered several resources during our live public input sessions, including Spanish language interpretation, communication access real-time translation or CART captioning, as well as live technology support. If you need any accommodations or additional resources in order to access this recording of the presentation, please contact the Oregon Health Authority. I have provided contact information at the close of this presentation. I'd like to introduce myself. My name is Dana Harganani. I use she, her pronouns. I am an advisor to the Oregon Health Authority's Director's Office and have been the lead on updating Oregon's crisis care guidance. I will be providing the presentation today. I'd like to make a note about public records. Information submitted for the purpose of providing feedback and comments to the Oregon Health Authority may be subject to public disclosure under Oregon Public Records Law. I want to acknowledge that the content in this presentation may be difficult. If today's content is difficult for you, please take steps you need to care for yourself. This might include stepping away from the presentation or contacting Oregon Health Authority's Health Security, Preparedness, and Response Program to find other ways to receive this information. The email address is health.security@odhsoha.oregon.gov, or our phone number is 971-673-1315. The following is the purpose of this presentation: to share background on Oregon's crisis care guidance, to describe changes to the new guidance, to explain how OHA's draft guidance would be used in a widespread emergency. Ultimately, we look forward to answering your questions about the guidance, should you have them, and listening to your input. Here is the agenda for this recorded presentation. Over these last few minutes, I've started with an introduction to this topic and presentation. Next, I will move into discussing background on crisis care guidance. Next, we'll review crisis care guidance history in Oregon, and then provide an overview of the new guidance. Finally, I'll give information about how to provide public input on the draft crisis care guidance, and close with some information regarding next steps. So first, we'll review background on crisis care guidance in Oregon. I'd like to start by providing information about two terms that are foundational to the topic of crisis care guidance. First is the term crisis standards of care. Crisis standards of care is health care that is provided differently than during normal operations. These changes are necessary due to a crisis, such as a widespread emergency or overwhelming disaster, when many people need health care at once. For example, during a pandemic or following a large earthquake. Crisis care guidance, on the other hand, is a tool that helps hospitals and healthcare providers make decisions in an emergency based on available resources. Another term that is important for this topic is the term triage. Triage is a common medical process that involves a quick evaluation of patients to determine the seriousness of their illness and who should be treated first. Triage is used every day in the healthcare system. It's used in outpatient clinics, emergency departments, trauma units, and many more environments. Triage is also a term that is used as part of crisis care guidance. During crisis care, triage refers to the prioritization process to determine which patients will receive life-saving resources when there are not enough for everyone who needs them. Crisis care triage is also called resource allocation, or sometimes is referred to as crisis standards of care. Crisis care triage includes several steps. The first step is to assess the likelihood of survival for each patient, and then to determine who will get treatment first. The topic of crisis care triage that I am presenting today specifically involves hospital settings and particularly life-saving resources. I do want to acknowledge that crisis care guidance is necessary for other areas of healthcare and healthcare resources, but the guidance that I'm speaking about today is specific to life-saving resources, such as those that would be needed within a hospital setting. This might include a mechanical ventilator, for example, to help someone breathe, a bed in the intensive care unit, or specialized staff needed to support those types of resources. So Oregon hospitals may need to use crisis care in the following circumstances. First, if their life-saving resources are severely limited. Also, if the number of patients who need those resources exceeds its capacity. And finally, if there is no option to transfer patients to other healthcare sites. I want to emphasize that OHA expects the need for crisis care triage to be rare. If a hospital has enough life-saving medical resources, it will offer them to all patients who may benefit. How will the public and others know when crisis care has been activated? Notification is an important step in this process. Hospitals must tell the public and Oregon Health Authority when crisis care standards are being used. If a hospital needs to use crisis care triage, they must comply with state regulations to post this information on their website and in the hospital. I want to emphasize, however, that when resources are scarce and many people need healthcare at once, there are many partners who must work together to try to maximize who gets care. The Oregon Health Authority will work with Oregon hospitals and other emergency response partners to maximize the capacity of the entire healthcare system and ensure needed care is provided to as many patients as possible. As I conclude this background section on Oregon's crisis care guidance, I want to acknowledge that there are many other areas we must focus on as part of emergency preparedness. While we expect that crisis care triage will be rarely needed, if at all, it is an important area for preparedness, but we also understand that broader efforts are essential to protect the public and reduce health inequities, such as ensuring ongoing emergency preparedness. That might include proactive resource planning and practicing emergency plans. We also must ensure access to culturally responsive healthcare, supports for patients with disabilities, a diverse healthcare workforce, coordination across regions, and partnerships with communities most affected by health inequities. Next, I'm going to provide a brief overview of the history of crisis care guidance in Oregon. The next two slides provide an overview of a timeline of crisis care guidance changes in Oregon. Starting in 2018, I'd like to acknowledge that crisis care guidance was published after a multi-year statewide health system effort in Oregon. Oregon Health Authority was involved in that process, including facilitating and hosting on our website crisis care guidance links for Oregon providers. This 2018 crisis care guidance was the last time that crisis care guidance had been updated in Oregon prior to the start of the COVID-19 pandemic. In the spring and summer of 2020, serious concerns were raised regarding the 2018 guidance. After taking time to review and learn about those concerns, OHA announced it would no longer rely on the 2018 guidance. We made that announcement in September 2020. In December 2020, OHA published a new document called Principles in Promoting Health Equity in Resource-Constrained Events as new guidance to support hospitals and healthcare providers should these types of decisions be needed during the COVID-19 pandemic. In January 2022, OHA published another update to Oregon's crisis care guidance. This document was called the Interim Oregon Crisis Care Tool. This document was published at the beginning of the Omicron surge during COVID-19. At the same time, we announced applications for a new advisory committee to the Oregon Health Authority. This committee, called the Oregon Resource Allocation Advisory Committee, or ORAC, was convened in May 2022 and met for just over a year. The committee presented and finalized their recommendations to the Oregon Health Authority in July 2023. Now in August 2024, OHA released a new Oregon Crisis Care draft for public input. That crisis care guidance draft is open for public input through September 20th, 2024. After OHA reviews the input we have received and makes needed changes, we will finalize this 2024 Oregon Crisis Care Guidance in the fall of 2024. I want to highlight the past concerns that came about regarding the 2018 crisis care guidance in Oregon. As I stated, many people had concerns about the 2018 guidance. Some filed a complaint with the federal government. The concerns we heard included that communities most impacted by health inequities did not have an opportunity to contribute or give feedback to the 2018 guidance. There were also serious concerns that the guidance would create barriers to healthcare and discriminate against people who experience inequitable burden of chronic health conditions, such as communities of color, tribal communities, and people with disabilities. I mentioned the Oregon Resource Allocation Advisory Committee. OHA brought this committee together in May 2022 to review crisis care guidance methods publicly, to learn about different views on crisis care, and to get input for new crisis care guidance. This committee included 25 committee members representing health systems, hospitals, clinics, public health, culturally specific organizations or communities, the disability community, the aging community, and beyond. It was important to OHA, and still is, to have diverse perspectives, expertise, and lived experience contribute to updated crisis care guidance in our state. We held meetings for over a year with ORAC members, and again, they completed their recommendations in July 2023. I want to acknowledge the commitments that OHA shared with ORAC members during the time that the committee was convened. We committed to center hope and innovation in our work and to not be limited by current practices or known options for triage, especially given some of the concerns about the options that have existed. We also committed to work to promote public health and achieve procedural justice through transparency, seeking community input on emerging recommendations, assessing local cultural values regarding resource allocation, and considering this information as part of guidance development. This public input process is important to this commitment. And finally, we committed to prioritizing input from communities who face the greatest health inequities. Throughout the course of the ORAC meetings, as well as OHA staff work to update the crisis care guidance, health equity has been central. I want to acknowledge this definition of health equity that the Oregon Health Authority has adopted. OHA believes that Oregon will have established a health system that creates health equity when all people can reach their full potential and well-being and are not disadvantaged by their race, ethnicity, language, disability, age, gender, gender identity, sexual orientation, social class, intersections among these communities or identities, or other socially determined circumstances. Achieving health equity requires the ongoing collaboration of all regions and sectors of the state, including tribal governments, to address the equitable distribution and redistribution of resources and power, and recognizing, reconciling, and rectifying historical and contemporary injustices. So as we center that definition about health equity, I will now move into showing how we've incorporated that into new draft crisis care guidance. In this next section, I will provide a high-level overview of the changes we've made to the new guidance. So how did we get to the updated guidance that we have now posted for public input? OHA considered the ORAC recommendations, past public input, and available research to inform the changes in the 2024 Oregon Crisis Care Guidance draft. After this new public input session, throughout August and September, OHA will consider all additional public input before finalizing the new 2024 Oregon Crisis Care Guidance. Once it is finalized, the new guidance will replace the 2022 Oregon Interim Crisis Care Tool. The first thing I want to acknowledge about the new guidance are the goals that we have stated for the new crisis care guidance. OHA has developed the 2024 Oregon Crisis Care Guidance draft based on the shared goals of saving lives and not worsening health inequities. Here is just a high-level overview of the key changes that we made to Oregon's crisis care guidance. We added a preface and a background section. We added a statement of goals for crisis care. We updated information about crisis care triage teams, and we revised the crisis care triage approach. Now we'll look section by section at some of the changes of the crisis care guidance draft. In the background section, we talk about the crisis care guidance history and definitions. As well, we provide information in this new background section about the Oregon Resource Allocation Advisory Committee, and the new guidance goals. I have just provided an overview of these items in the last few slides. The next section of the new Oregon Crisis Care Guidance draft is focused on crisis care assumptions. The first section here is focused on when crisis care would be activated and the importance of individualized assessments. We also spend time in this section looking at patient care preferences and the importance that patient care preferences are considered even during the time of an emergency. We also spend time in this section of the guidance draft talking about the crisis care triage team. A crisis care triage team is a team of individuals who come together to assess hospital survivability of patients needing life-saving resources when those resources are limited, and makes decisions about who will be prioritized. In our prior guidance, we talked about the types of members that should be included on the triage team and the type of training they should have. In this new guidance, we've added additional members as recommended by the ORAC committee. This includes a representative from the community, perhaps such as a community health worker, and an interpreter to support communication. We've added additional training, such as training for the triage team to create, assess, and support an environment that does not activate bias. We've also called out the importance for hospital leadership to support triage team members in this difficult role that they may have to take on. The next section of the guidance focuses on crisis care triage. First, I'm going to provide an overview of the key changes in the new crisis care triage, and then I'll walk through the steps, for example. At a high level, the changes that we have made in this new crisis care draft guidance, we have removed the use of a tool called the Sequential Organ Failure Assessment, or SOFA tool. This tool has been used widely in crisis care guidance documents across the United States, and it has continued use in those documents today. However, there has been substantial evidence and research to show that SOFA tool in application within crisis care guidance is not accurate and would worsen health outcomes, particularly for Black patients. For this reason, we have removed the use of this tool from crisis care triage moving forward. Also, changes in the crisis care triage include providing information about how the triage team should assess patients' prognosis for hospital survival, including specific objective medical information. We've also changed how we use this hospital survival prognosis information. In the new guidance, this type of information is used to assign patients to triage priority groups, rather than ranking individual patients in order of their individual estimated hospital prognosis. I will share more about this in a few minutes. And finally, we used to have pure randomization as the approach to a tiebreaker when needed in our past guidance. Our new guidance replaces randomization with something called equitable chances criteria in the case a tiebreaker situation occurs. So let's review the crisis care triage steps in more detail. First, I'd like to highlight that the patients involved in a triage step like I'm describing today include, first of all, a situation where there are many people needing healthcare at once, and that there is a limited resource, such as a ventilator, where there's not enough of that resource for every patient who needs it. So when I talk about determining which patient or patients get the life-saving resource that's in short supply, we're only talking about the patients who've been deemed to need that resource, who require intensive care services, who need a resource in order to survive. If there are not enough resource for everybody who needs it, the following steps would take place according to the guidance. First, the triage team would take the step of estimating each patient's chances of survival in the hospital using precise clinical information. This includes specific data related to the function of the heart, lungs, kidneys, blood, liver, and brain. It's very important to note that a triage team must use reasonable modifications to assess patients with disabilities. In this next step, the triage team would group patients into 4 priority levels based on the triage team's estimation of each patient's hospital survival chances if they were to receive the resource. For example, all patients who are estimated to have a greater than or equal to 90% likelihood of surviving their hospital stay if they receive the resource they need, they would be placed into group 1. Patients who are grouped into group 2 would be those patients who were estimated to have an 89 to 50% chance of hospital survival, and so forth. There always needs to be a pause by the triage team to check for consistency for how these steps are being considered, and as well a check for bias. Any identification of inconsistencies or bias being applied, those estimates should be redone. Finally, once that check has been completed, assignment of patients to the triage priority groups is finalized. Patients in group 1 would receive the highest priority for the resource. Patients who are placed into group 4 would get the lowest priority for the resource. Ultimately, the amount of resource available will determine how many people get the needed life-saving resource. If there are not enough resources for everyone within the same priority group, then a triage team would need to move into a tiebreaker decision. In this step, we outline in the new guidance to use the equitable chances tiebreaker criteria, which I will review in just a moment. For any patient that does not receive the needed resource because they were not in the prioritized group, their care should continue and they should be placed on the waiting list for the resource. Reassessments will be done over a relatively short amount of time, as outlined in the guidance, to reassess all of these steps for patients who continue to need the resource. Now let's move on to provide an overview of the equitable chances tiebreaker. As I just shared, hospitals will need a tiebreaker if more patients are in a triage priority group than resources available. For all patients who are needing the limited medical resource and aren't receiving it already, the equitable chances process is used to break a tie. In this way, all patients have a chance to get the life-saving resource. Some patients will get additional priority beyond equal chance if regional data shows they are more likely to be impacted by the emergency. Let's look at how this would work. So as part of the equitable chances process, the first step is that patients who are needing the resource and have equal prioritization for that scarce resource, their home address would be identified. And based on the patient's home address, the team would need to identify their disadvantage score, or other words, a decile, a number from 1 through 10, using nationally available data called a disadvantage index. Next step, the team would have to use data published from the Oregon Health Authority that shows the estimated impact of the emergency for people according to their disadvantage score in step 2. This information is used to determine if any patient will get extra chances or extra weighting during a randomization process to get the resource compared to other patients. In these steps, I highlighted the role of assessing relative disadvantage. And here we recommend using a disadvantage index. The example disadvantage index we've highlighted in the Crisis Care Guidance draft document includes the Area Deprivation Index, or ADI. The ADI includes 17 total factors measured across 4 themes, including income, education, employment, and housing quality. These factors are measured at the local neighborhood level. This is also called a census block. The data utilized for informing these measures includes data received from the American Community Survey at a national level. This Area Deprivation Index is maintained and validated by the University of Wisconsin. During COVID-19 pandemic and afterward, disadvantage indices like the ADI were shown to have strong correlation with outcomes from the COVID-19 pandemic, such as mortality. In other words, those who faced the greatest disadvantage as measured by the ADI and other similar measurement tools had the worst outcomes as measured by mortality from COVID-19. So to provide a little bit more example of how this equitable chances criteria would be applied. Again, this is a weighted process that gives higher chances to receive a limited life-saving resource to patients in proportion to their estimated impact by the emergency. So as an example, let's say there's a group of patients who have been determined to have similar hospital survival estimates, and there's not enough resources for all of them. One of those patients has the highest disadvantage score according to their home address. In other words, their disadvantage score is 10. Looking at data available in Oregon related to the current emergency, we could see in this example that the estimated impact associated with a disadvantage score of 10 is 3 times higher than for someone with the lowest disadvantage score. Using the equitable chances tiebreaker, this patient's chance of getting the needed resource would be increased by 3 times. Again, this extra weighting according to impact would be processed using a randomization weighted process, and this can be applied such as available software through a computer system that a hospital would have access to. At this point, I will just highlight the last few sections of Oregon's crisis care guidance, but invite you to review the guidance on our website in more detail. The last and important sections of the guidance include topics such as the importance and details about transparent communication, data collection if crisis care triage is applied and activated, And finally, an important focus on innovation and prevention moving forward. This ends the overview of the changes that OHA has made regarding Oregon's crisis care guidance. We really believe in the importance of procedural justice and are looking for as many people as possible to review the guidance and provide public input before we move forward to finalize the guidance. We want to learn from you and hear your opinions. Some resources that we have provided to help you provide public input include the following. First, you can access the 2024 Oregon Crisis Care Guidance draft on OHA's website at www.oregon.gov/crisiscareguidance. We have also prepared additional resources to support engagement with this complex topic. This includes a plain language summary of the technical guidance. This describes crisis care guidance in plain terms. We also have a short video available in English, ASL, and Spanish available for your review. We have also created a frequently asked questions or FAQ document with answers to frequently asked questions. And finally, we have a web page devoted to crisis care guidance with information about these resources. I want to also acknowledge that the 2024 Oregon Crisis Care Guidance draft and supporting resources are available in the following languages on the OHA website. There are a total of 13 languages as listed on this slide. I also want to acknowledge that accessibility is important to the Oregon Health Authority. You can get the 2024 Oregon Crisis Care Guidance draft document free of charge in other languages, if they weren't listed on the prior slide, in large print, Braille, or a format you prefer. Please contact the Health Security, Preparedness, and Response Program at health.security@odhsoha.oregon.gov or by calling us at 971-673-1315. We accept all relay calls. In this slide, we provide information about options for providing public input. You can provide your input to OHA regarding the draft guidance in multiple ways. During the public input sessions that were hosted live in August, participants were able to write down or verbally share their input during those Zoom meetings. At this point, we invite you to provide input by either completing a short survey. The link is provided here on the slide as well as on our website, and the short survey is available currently in 13 languages, or to send an email to health.security@odhsoha.oregon.gov if you would like to share your feedback via email. We really hope that you will consider providing public input on OHA's Crisis Care Guidance draft so that we can consider your input and lived experience prior to updating the guidance this year. Again, thank you for your time, and please do reach out to us if you would like to access the Crisis Care Guidance or this presentation in other languages or formats. I thank you for listening to this information and again encourage you to provide input to OHA regarding the draft guidance. Have a great day.